Our next speaker is Dr. Zed Zha. She is a board-certified family physician. She graduated from the Geisel School of Medicine at Dartmouth, where she received the Gold Humanism Honor Award and the John F. Radabaugh Community Service Award. She completed residency at the Mayo Clinic La Crosse Family Medicine Residency, where she received the Resident Research Award. She also served as her organization's COVID-19 Task Force Physician Lead during the first year of the pandemic. Currently, she is a fellow at the Underserved Dermatology Fellowship in San Antonio, Texas. At this time, I will turn the floor over to Dr. Zed Zha, who will present on workplace violence against healthcare workers. Thank you.
Well, thank you for the introduction. Hopefully in the next 30 minutes or so, I am going to take a deep dive into the workplace violence issue against healthcare workers with you. This is an escalating global issue, so I'm glad everybody from all different parts of the world are here. I will touch on these topics in this issue, including the definition, prevalence, how has the pandemic impacted us, who are the victims, what are the motives behind the violence, who are the perpetrators, what happens afterwards, and also what should happen in the future. I would like to disclose that I would not be focusing on bullying, which is a type of workplace violence, but among colleagues, and I would not be going into details. I would talk about it, but I'll not go into details about safety measures to prevent or de-escalate violence, because I think these topics belong into a bigger and larger workshop for a prolonged period of time. So what constitutes workplace violence? According to the WHO, these are incidents where staff are abused, threatened, or assaulted in circumstances related to their work, including commuting to and from work, involving any explicit or implicit challenge to their safety, well-being, or health. And according to WHO, there is a separate type of violence, which is psychological. This includes any intentional use of power, including threat, physical violence against another personal group, and can result in harm to physical, mental, spiritual, moral, or social development. OSHA defines workplace violence as well, and they pointed out that this can range from verbal to physical to even homicide, which we'll talk about, but it can also involve workers, clients, customers, and sometimes bystanders as well. In the literature of this topic, generally people categorize workplace violence against healthcare workers into 4 different types. Type 1 is committed by a random person, and type 2 are committed by patients or customers, and I would add even the relatives of the patients as well, which I'll show you. And type 3 by current or former employees, such as bullying, which we will not talk about. And type 4 are done by people who have personal relationship with the worker, but not the workplace. So let's talk about prevalence. There are 2 sentinel meta-analyses of this topic before the pandemic. The most recent one was a 2020 study that looked at over 300,000 healthcare workers in the past 1 year prior to the study. The prevalence showed about 62% people were exposed to some sort of workplace violence, 42% were non-physical, and 24.4% were physical, and there's some overlap in between the 2 as well. The most common type of non-physical violence was verbal, and we have to pay attention to threats and sexual harassment as well. The second meta-analysis was published just a year prior to that, looking at over 980 articles. This report estimated that verbal abuse was up to 59%, physical abuse up to 22%, which are pretty comparable to the next year. And sexual harassment was pointed out in this report as well, which is interestingly prevalent in dentistry or oral health, up to 54% of sexual harassment prevalence. Some studies show, in this Nigerian study in 2011, showed the prevalence of workplace violence in general in oral health was 32%. They suspected that this has to do with the fact that oral health is female predominant staffing. There's usually long wait time, really high patient volume, and sometimes people don't understand the care outcome. Only about 18%, and I say only with the quotation mark, is physical, but we have to note the fact that people who do get physically violent in this setting do have really easy access to sharp instruments due to the work environment. This slide is really busy and I would not read it. but this summarizes the predominant research data on the prevalence of workplace violence around the globe. As you can tell, this is really, truly a hidden pandemic on top of a pandemic. I would like to go into details about the data coming from China, because fortunately and unfortunately, China has really excellent data on this topic due to its really high prevalence for a very long period of time. From my personal experience as a physician who started her training and grew up in China, there are really important lessons for us to learn from these data. So let's look at it. If you look at the graph on the right upper hand, it looks like since the year 2000, workplace violence against healthcare workers has been on the rise, especially since 2012, seems to have peaked around 2012, 2013. In 2012 alone, 7 healthcare workers were killed. We're talking about homicides in the country, in China. And in 2008, the non-physical abuse prevalence was astonishingly high already at 90%. In 2012, it went to 96%. Physical abuse went from about 50% to 63.7% in 2012. And number of assaults per hospital per year went from about 20.6 or 21 to 27.3 in 2012. So pretty big elevation. And it looks like perhaps it's coming back down, the numbers coming back down. In 2020, the most recent survey, over 3,700 participants, the prevalence at this point was about 56%, about 16% were physical assaults. This is an interesting picture, is actually from a 2006 news article in China that showed that the hospital was recommending wearing a helmet to work as a safety measure for healthcare workers. And we have to pay attention to the fact that this was a decade before masks were recognized as protective for healthcare workers. The casualties are serious. We know this, once again, because of over a decade worth of data from China. And this graph shows serious workplace violence. And I'm talking about serious, like physical injuries against healthcare workers. And as you can tell, 2012 starting going up, and 2016 peaked, and then now perhaps is starting to come down. So between 2004 to 2018, over about a decade of time, 264 reports of serious injuries happened in China. 13% resulted in death, which means 34 people died of homicide at work as healthcare workers. 6% was serious or severe injuries, which really sounds very, very severe. Pierced heart, paralysis of both lower extremities, decapitation of arm, or intestinal perforation. Even the 26% that were minor trauma, really, they're not minor to my standard. This includes intracranial hemorrhage, orbital fracture, concussion, miscarriage, burn, tendon rupture, or lung contusion. Even the slight injuries, and I'll let you read it yourself, 31% were slight injuries. And to be honest, they're not very slight to start with. So now we ask ourselves the important question: how has the pandemic impacted this trend? I think we all have the answer in our heart intuitively, but what does the data actually say? The early data that came out of the first 6 months of the pandemic, I don't think it reflected the extent of the problem, because the Red Cross estimated about over 600 cases of intimidation and stigma against nurses in 40 different countries. Meta-analysis of 17 studies, which is over 17,000 participants, estimated about 17% physical violence and 44% non-physical violence, 47% among nurses and more among physicians. The prevalence may not appear to have increased that much during the first 6 months of the pandemic. However, about 1 year into the pandemic, a few internationally important organizations sent out a global survey, and the participating countries are shown in this map, asking them one question: do you see in your organization an increase in healthcare workplace violence against healthcare workers since the pandemic? And you can tell from the result, majority of the organizations and countries said yes. So now let's look at some newer data on this topic. April this year, 2022. In the month of April, over 1,000 participants reported 9 in 10 people have experienced or been in close proximity to violence from a patient or a patient's caregiver. And 3 in 4 have encountered both verbal and physical assaults. And nearly 50% needed to call for security or another coworker to assist. So it seems like the numbers are definitely going up. So this website is Insecurity Insight. They provide an interactive map that tracks healthcare related crimes and provide us with a more direct way to visualize this hidden pandemic. You can put in the time frame and see the incidents that have been reported around the world. I played with some numbers. 2 years leading to the pandemic, which is March 2018 to March 2020, 2,127 incidents took place, resulting in 279 healthcare worker death, which is homicides around the world. And if we look into the 2 years into the pandemic, so March to March, 2020 to 2022, this number rose to 2,724, and homicide rose to 326. So these are the numbers we're looking at for the pandemic of violence on top of the COVID-19 pandemic. So who are at risk to become victims? In the literature, these are typically listed as departments that are at higher risk. As you can imagine, emergency room, drug and alcohol clinics, like we talked about dentistry and OBGYN, which is high liability anyway. And these are the work settings that give people higher risk. So if you're working remote sites where you're isolated, understaffed, or if your place has high crime area and you reside in a high crime area, these are the risk factors. However, a 2019 meta-analysis of over 13 articles reported most doctors, this is a doctor-specific research, most doctors were susceptible to type 2, which is by patient or patient relatives, workplace violence, regardless of their work environment, organizational culture and structure, or access to resources. So who are at risk? The short answer is all of us are at risk. On an individual level, what are the risk factors that make an individual more likely to experience violence? According to the WHO, these are the risk factors. So female more likely than male, especially when it comes to sexual harassment. Members of minorities, like the previous speaker also talked about. Also, people in training who appear to be more inexperienced are more likely to be, or younger people are more likely to be experiencing this. The research data is conflicting on wearing name tag or wearing uniforms. Some studies show that they're actually protective, and some studies show that they're harmful. I think it is worth mentioning that there's another category of workplace violence that cannot be ignored, which is racially motivated. So earlier this year, February 2022, the immediate past president of American Medical Association, Dr. Harmon, published this article called "Threats, Intimidation Against Doctors and Healthcare Workers Must End." In this article, he pointed out that the racially motivated violence is on the rise, especially against Asian Americans. And WHO also has a separate category of racial harassment listed as one of the workplace violences as well. So, and I think majority of us in this audience probably can think of personal examples of this as well, unfortunately. I do want to talk a little bit about this. AAPI stands for Asian American Pacific Islander. So the anti-AAPI hate during the pandemic was quite astonishing as well. Just to give you a little bit of background, the most recent data shows that in the United States, AAPI population takes up about 6% of the US population in general. However, we make up 20% of non-surgeon physicians and pharmacists, and 12 to 15% of surgeons, physical therapists, and physician assistants. I think this speaks to the model citizen or model minority status of the AAPI people. But where has it landed us during the pandemic? That's the question. Prior to the pandemic, 31 to 50% of AAPI physicians experienced on-the-job discrimination. This is lower than Black physicians, but higher than any other racial group. Since the pandemic, police report of anti-Asian hate crimes shot up by 146% in 2020 alone, while hate crime overall only rose to 2%. In the month of April 2020, which is the second month of the pandemic, only 1% of non-AAPI healthcare workers reported that they experienced racism, but 20% of Asian healthcare workers reported racism during the same time frame. So now let's look at the motives behind the violence toward healthcare workers, particularly what would motivate somebody to commit really serious attacks or physical attacks. On the surface, if you look through different organizational official postings, most of the data show these three different categories of motives for violence. So mental health, which includes cognitive dysfunction, which includes dementia. So as you can imagine, your older terminal dementia can result in aggressive behavior. Another category is drug and alcohol. And then it's the patients and visitors' inability to deal with a crisis situation as main three categories. However, if we really look at the current data on serious crimes, and I'm talking about crimes that resulted in physical injury or death, it becomes clear that the number one motive is actually dissatisfaction with care. And the number two is unreasonable request from the patient or a family. And the last and the smallest category is actually the mental health and intoxication. What does that tell us? I think this tells us, like most cases of violence in the world today, when you really look into the actual data, it is clear to me and to everybody that it's unfair to blame it all on mental health if it's not just stigmatizing. To blame it on mental health simply does not reflect the truth or the facts. So who are the perpetrators? So in this Minnesota nurse study in 2004, most of the verbal violence came from younger men, and older men are more likely to cause physical violence. However, I think this data is probably heavily influenced by the data from nursing home residents, like we talked about with cognitive issues and aggressive behavior to start with. And despite common belief, only 5% were done by young people younger than 17, so teenagers were not the troublemakers in this study. Going back to the serious attack data that came out of China, majority of the serious physical attacks were done actually by the relatives of the patients in this particular study. This is big data study, but I think that speaks to the close-knit family structure in the Chinese society. And then the second biggest category is patients. Occasionally it's both. Sometimes it's a random person. So the question is, after the violence happened, what was actually done? Unfortunately, most people did nothing. Most people did not take any action to deal with the violence that they encountered. In 2009, there's a Brazil study over 250 survey that showed only 9% of sexual harassments were reported and 0% filed complaints. In 2015, in the United States, also a survey study, the prevalence at that point was 62% workplace violence, and 88% of these were actually not reported. Similarly, in 2021 in China, the prevalence was once again about 65%. Only 25% were formally reported. And when you ask healthcare workers why didn't they report it, 50% is that either they didn't know there was a reporting system or they didn't know how to use it. And 51% of the nurses actually reported that they felt the hospital would pay more attention to the patients than themselves, so they didn't feel protected anyway. According to OSHA and available research, these are the main reasons why people don't speak up against the violence they experience. And I highlighted these ones that contribute to trivialization, which is, people say, oh, it's just part of the job, or there's lack of reporting system, or people don't trust the reporting system. Or sometimes people feel that if they report the violence, they would appear to be incompetent at their job. These contribute to the trivialization culture in healthcare organizations, which means it's not just normalizing violence, but actually dismissing them. The trivialization of violence against healthcare workers isn't just an organization issue. It can be a societal issue as well. And I'd like to demonstrate this point with a really well-publicized case in China. In 2015, July, Guangzhou, China, 36-year-old female physician was rounding in the hospital when a 34-year-old male patient showed up demanding to be seen by her because she saw him over a year ago. And the doctor said, I'll see you, but just not right now. I need to finish rounds first. At this point, the perpetrator pulled out a kitchen cleaver that he brought, stabbed the victim multiple times. Luckily, surveillance camera captured everything, and this was later leaked onto the internet, which was publicly accessible. It's no longer accessible now, but for a while it was viral. And so a few months later, the perpetrator was deemed to be mentally stable, able to take full responsibility. However, this was how severe the stabbing was. The sentencing was only 2 years in prison, this perpetrator. This is a very interesting study, and I like to see more of studies like this in the rest of the world as well. So because the video went viral, there was a study that looked at the microblogging, which is like Twitter or Instagram, people's comments on this particular incident I just talked about. Over 664 microblogs were analyzed. Only 56%, just about 50% actually showed any sympathy for the injured physician. And 23% explicitly condemned the violence. 43% didn't show any emotion toward the incidents. And 10% people who are healthcare workers said that they're going to quit their job. And 3 people actually recalled their own experience at the hospital, criticizing the hospital's poor medical conditions and doctors' attitude. And 2 even blamed the doctors for the incident, so they took the attacker's side. And 0 actually came from legal or administrative authorities. So as you can see, the public societal response online did not actually reflect the moral value we like to see in the public. People were not as sympathetic as toward the victim as we would imagine. Growing up and having come from China, I could understand to some extent why this is. It's a really complicated and deep-seated societal issue, but I hope that this phenomenon is not replicated anywhere else. But I really would be interested in seeing more similar studies in the US and other parts of the world as well. So what happens next as a result of unsafe work environment in healthcare? Research and common sense tell us if we let this go on, these are going to be the outcomes. People will get burnt out. There's depression, dissatisfaction with their job, PTSD, practicing defensive medicine, and perhaps more worrisome from a logistic perspective, decreased staff retention. People leave their jobs that make them feel unsafe. In fact, the Great Resignation has already happened in healthcare. According to a 2021 Washington Post Kaiser Family Foundation survey, 30% of healthcare workers surveyed were considering leaving their profession as we speak. And 60% of healthcare workers reported impact to their mental health stemming from the work during the COVID-19 pandemic. And I looked at the statistics from the US Bureau of Labor and Access. This was about 2 weeks ago. In the second quarter of this year alone, 1.6 million people have quit their jobs in healthcare. To make matters worse, currently, these are the predictions from different organizations of the shortage of healthcare workers in the near future. I'd like to point out the Mercer prediction at the bottom. So 2025 and 2026 are really just a few years from now. We could be in 3 to 4 more years, we could be looking at 3.2 million people shortage in the healthcare fields. And unfortunately, as we learned from the Chinese data, in the face of such unsafe work environment, less than 1 in 4 people would have gone into medicine if they knew the risks. And more than 9 in 10 people will actively talk their children out of going to medicine. But if these outcomes in China are generalizable to the rest of the world, then I think the fate of healthcare is in trouble internationally. So what can we do about the violence we face at work? I'm not an expert on policy changes, although I do think that most of the work on this issue has to be done from a policy-making level. I like to talk about from an organizational level, what can we do? Number 1, from a smaller scale within an organization, does prevention actually work? The results are pretty conflicting. I think one of the best quality research was 2017, a randomized control trial that looked at 7 hospitals over 5 years of a time span, where there is a hospital-specific, data-driven risk identification program, followed by an intervention plan that were implemented. And the evaluation of incidents of violence were looked at 6, 12, 18, and 24 months after intervention. As you can see, at 6 months post-intervention, the intervention did make a huge difference in rate of violence event, did reduce quite a bit of the violence events in these hospitals. However, if you keep going, looking at the data, at 24 months, the difference disappears. And the rates in both groups actually reached the highest, and both were significantly higher than the baseline from the beginning of the study. What does that result tell us? This might suggest that the initial positive effect of the intervention from a prevention perspective were not maintained. How about during the incident? What can we do to de-escalate? In general, there are a few types of de-escalation trainings, and they should be done by professionals. In the research, what really works is multi-component intervention, including it has to involve all the stakeholders, including the people who work in admin in the hospital and in clinics. You have to clearly define what violence is and how to trigger intervention. Identify high-risk units. The facility equipment just have to be in place so people can actually sound the alarm. Policy changes have to happen within the organization. And these type of de-escalation trainings really need to be done by professionals who are proficient in this type of training program. And needless to say, as previously demonstrated, it's important to have post-incident reporting and support systems for the victims and families. Last but not least, should we be imposing harsher legal punishment for these crimes? We don't actually know the answer to that. We don't know if harsher punishment means less incidents or if that's a good means for prevention. But in the United States, it's been talked about. Some states are actually consider, or they have already implemented some of the penalties. Some states are considering making the penalties for attacking a healthcare worker the same as attacking a police officer or other first responders, making it illegal for somebody to threaten a healthcare worker, official, and things like that, which I thought was already illegal, but I guess it's not really yet in some states. As we speak, like I said, this Prevention Act has passed the House and now is being considered in the Senate. Just as we're all struggling to figure out how to solve this hidden pandemic of healthcare worker workplace violence, I think our newest challenge revealed itself recently in the past few months to years, and it's making this hidden pandemic not so hidden anymore. On June 1st, 2022, Michael Lewis opened fire in a hospital in Tulsa, Oklahoma, killing 4 people, and these are the 4 victims listed. I think incidents like this raise a chilling question. Are we entering a new era of workplace violence with more lethal weapons? I really hope the answer is no. This is the end of my presentation. Thank you, everybody, and I hope you stay safe. And these are my references if anybody has more questions.